So first of all, thank you for inviting me. It sort of feels like coming to a family party because I know almost everybody in the room, and it's a pleasure to see you all again. And I'm smiling for the camera. So what am I going to talk about? Well, first of all, most people when they give a talk, as Bettina did, finish off with the acknowledgements. I thought it'd be nice to turn it back to front and start off with the acknowledgements. And I think first of all, the most important people to acknowledge are the patients and their families who've done so much to fundraise for what we now call NCCA, and also for a range of other neuroblastoma charities, and also for general cancer charities, all of which have contributed money to research, and without whom we wouldn't get anywhere. The NHS provides a lot of the basic stuff, but it is inadequate by itself and it needs more support from charity. So what I'm going to be talking about really are aspects of radiotherapy as related to neuroblastoma. And I think first of all we must ask the question, what is radiotherapy? I realise that in addition to the healthcare professionals in the room, the parents, you lot, come with a very varying degree of background knowledge. Some people have got degrees in physics, but I'm going to try and aim this at the lowest level so that everybody understands, and if some people who know more think that I'm trying to teach their granny to suck eggs, well, I'm sorry about that, but I want everybody to understand what we're talking about. So what is radiotherapy? And I think the simple answer to that is that radiotherapy is the use of ionizing radiation. By that we mean high energy radiation which will interact with atoms and molecules and cause disruption there. And we use that energy to kill cancer cells. So that demystifies radiotherapy. Radiotherapy is using radiation to kill cancer cells. And radiation for killing cancer cells is really good. It does what it says in the tin, it does the job. But there is a but, a small but, and that is that radiation, as well as killing cancer cells, can also damage healthy, normal cells. And that causes a lot of fear and anxiety and worry. Is the radiotherapy going to do more harm than good? And so when we do research in radiotherapy, it's not just trying to find out whether radiotherapy is effective against cancer, because we know it is. It's a very, very effective treatment. What we're trying to do is to use it more smartly, use it more cleverly, so that we can treat the cancer and spare the healthy, normal tissues. And so the big question is, how can you make radiation kill more cancer cells and fewer healthy, normal cells? Because if you can do that, you'll make things better. So what you need to do is to make sure that the radiation goes to the right place. Sometimes it's easy to know where the right place is because you can see it very clearly defined on a scan. Sometimes the right place is much more diffuse. It may be much more tangled up with healthy, normal cells, and that can make things more challenging. And we can also exploit the biological differences between cells. Not every cell is the same, and we can use molecular methods both for imaging cancers to see better, more accurately where they are, but also for treatment. So better targeting of radiotherapy is what we're after, and we can use physical means to do that, and we can also try and use various biological methods to get the radiation where we want it to go. So thinking about the physical methods and the biological methods, in this talk I'm going to cover 4 separate but related ways of treating neuroblastoma. So firstly, using the most modern types of conventional X-ray based radiotherapy. We have a technique which goes under a number of different names, but I would call it IMAT for short. IMAT stands for intensity modulated arc therapy, but you don't need to remember that, but use the handle IMAT. And the second way is to talk about proton therapy, which doesn't use X-rays, but it uses a form of particle which is accelerated to high velocity. And amongst the biological methods, there's targeted radiotherapy with 177 lutetium dotatate. That's a bit of a mouthful, so we just call it LuDo for short. And you saw that MIBG, somewhere between 2006 and 2009, it became a very big word. Now it seems to have faded a little, but it's still a very valuable treatment for many patients with neuroblastoma, but we want to use it more cleverly, and we want to assess its use in comparison with other things. So those are the 4 areas that I'll cover, and so now we will start off on the intensity modulated arc therapy, or as you remember, it's called IMAT for short. So essentially ordinary radiotherapy, the radiotherapy that we had no choice but to use 20, 15, 10 years ago, was quite simple. But over the last 10 or 15 years under development, and the last 5 years or so in fairly widespread practice, there have been great strides made in the technical delivery of radiotherapy, and this is where IMAT fits in. So ordinary radiotherapy, very often for treating neuroblastoma, used just 2 rectangular beams. Okay, so you could shape them a little bit, but essentially it meant that you were treating, for example, the middle of the tummy, a big solid block of tissue, and here you can see a scan of a child. There's an MRI scan on the left, and on the right is an old-fashioned radiotherapy simulator film that essentially just shows a big rectangle covering the area that you're trying to treat. And so everything covered by that rectangle would have been treated. So the tumour would have been well treated by the X-rays. The normal tissues were at risk of being damaged by the X-rays. So there are problems with simple radiotherapy in that lots of normal healthy tissue can get in the way and is subject to damage. As many of you are aware, we collaborate internationally, and the European Neuroblastoma Clinical Trials Group that we work with, that covers most of the countries in Europe, is called CIAPEN, and within the CIAPEN organisation there is a radiotherapy group, and we have looked in that at developing ways of analysing how radiotherapy has been given in everyday practice, seeing whether it's good enough, seeing whether it could be better. So we've run a quality assurance program, and we have previously published the methodology for how we looked at the quality of radiotherapy. And we have reviewed the radiotherapy given to 100 patients. That's not a big number, but it's quite a lot of work to review the radiotherapy plans for each child. And we found that only about half had what we called compliant radiotherapy. That is where the radiotherapy that was actually delivered was exactly as the protocol intended. And in the other half, there was non-compliance for one reason or another, and in the vast majority of cases which we felt were not compliant with the protocol, it wasn't because there were bad doctors giving the radiotherapy, it's because there were good doctors giving the radiotherapy, and they felt that they needed to change the plan in order to protect normal tissues. As you know, neuroblastomas are most commonly situated at the back of the abdomen around the level of the kidneys, and your kidneys are quite important to you. Your kidneys are good friends. You want them to work well. If your kidneys don't work well, you can end up with problems. And unfortunately, kidneys are relatively sensitive to radiation damage. So we need better ways of giving radiotherapy than we've had in the past. And just one little audit in our own department. This shows 10 patients. The aim in every patient was to give 21 Gray, and you can see that this group of patients are ones who are all non-compliant. And so the phase 1, which is the dark colour at the bottom, is when you decide on the ideal tumour volume to get the dose and the dose that was given. So in all those patients, less than 21 Gray was given. In the ones that have got the pale blue bit that goes up to the top, it means that a second phase of treatment was given to take part of the volume that we needed to treat up to 21, but we couldn't take the whole volume up because we didn't want to damage things. So that's conventional radiotherapy for you. This is historical data. But I'm pleased to say that IMAT is different. It's a rotational therapy. So instead of the radiotherapy machine being in a fixed position, it actually moves around the patient during the time that the patient is having treatment. As you know, there are 360 degrees in a circle. So as this goes round, every 2 degrees of rotation, there's something different. So by the time it's done a whole circle, it's effectively delivered 180 different radiotherapy fields. The speed of rotation can change as it goes round, and the intensity of the amount of radiation that comes out can also be changed during the rotation. So is this all smoke and mirrors? No, not really. It's quite good computer science. And I think really it's been putting the man on the moon and the development in computing powers over the last 20, 30, 40 years that have really made a difference. The doctor will prescribe dose constraints to various organs, so we'll say we don't want the kidneys to get more than such and such, but we do want the tumour to get this amount, and the computer works out the best way of doing it. And you get very complicated things like this, where the speed of the rotation varies, where the dose rate coming out of the machine varies, and at the same time the shape of what is being treated varies. So just one or two comparisons. On the left you see a conventional treatment. The area circled in red is the bit we want to treat, but in fact, because we're treating just from the front to the back, a lot of normal tissue gets treated, including the whole of the right kidney, which is sitting at the back. With IMAT, which we use under the trade name of Rapid Arc, that's what the manufacturers call it, you can shape the high dose volume much more nicely. You can spare much more normal tissue. And that can be shown on graphs. If you look at the left kidney here, as it moves back, it shows that less of the kidney is being treated and less of the liver, and there's better coverage of the target volume that's called PTV. This is another patient who historically was treated with a two-phase technique. So low dose was given to the wider area and a higher dose to the narrower area in order not to exceed the dose which the kidneys would like on either side. But with IMAT, you can get a much better dose distribution. And again, you can see that the curves move a bit to the left, sparing normal tissue. What those pictures don't show you is what these ones do, is that as you do that, you actually spread low dose wider over normal tissues, but that in general is likely to be safe. So we did a dosimetric study of 20 patients who'd previously been treated. 10 were protocol compliant, 10 were not, and we showed that the use of IMAT would have enabled the full dose to have been given to 18 out of the 20 patients. So that's a significant improvement. And Now we move on to protons. Protons are different. Protons are particles. They go in so far into tissue, and then they release all their energy and they stop. The other thing that most people don't realize is that protons are in fact the same dose for dose in terms of the normal damage they cause to cells. So anything in the high dose volume treated with protons will be equally damaged compared with normal radiotherapy. The advantage of protons is that they can reduce healthy normal tissue being irradiated. And this is a nice little graph which the physicists will understand. So if you think of a beam coming in this way and penetrating 10, 20, 30, 40 centimetres deep with ordinary radiotherapy, that's this one called photons. Most of the dose is delivered just under the skin, and gradually over depth there is still dose. With protons, there's a certain amount going in, there's a big whoosh as most of the energy is let out, and then nothing beyond. And so this is not a neuroblastoma, but it's an eye being treated, and you can see X-rays on the left. Yes, you can give a nice high dose to the eye, but the whole of the rest that's coloured blue gets a low dose, which can potentially cause harm. With protons, you get a much neater dose distribution. So the NHS now funds proton therapy for patients to go abroad for treatment, because we don't have treatment facilities in this country yet. There is a limited range of indications that the NHS has agreed to fund where there is significant benefit over conventional radiotherapy. Protons work best for small, localized tumours such as brain tumours. Most neuroblastomas don't fit into that category, and so neuroblastoma is not at the moment on this list. We will have 2 English centres, one in Manchester and one in London, open by 2018. The plans for these are quite far advanced, and the Treasury has approved the funding of them. So coming on now to molecular radiotherapy, this is biological targeting. It's nice and dramatic to think of 2 things. You have a missile that takes off and then deposits its energy in the tumour and destroys it. So you have the missile that takes it there and the warhead that explodes. That's the radioactive bit. And if you think about a neuroblastoma cell, it has molecules on its cell surface, the noradrenaline transporter that takes up MIBG, the somatostatin receptor that takes up peptides like dotatate, and also GD2, which you know about from immunotherapy targeting. And so there are lots of targets on neuroblastoma that you can attack with molecular radiotherapy. You can see where the tumour is on a scan, and you give a radioactive drug, and it goes around the bloodstream and ends up at the tumour. So we have a trial called LuDo for this drug called lutetium dotatate, which is now open for patients with relapsed or refractory disease. Lutetium dotatate is an established treatment in adults with neuroendocrine cancers. Neuroblastoma tumours are known to express this thing called SSTR2, and we can do imaging with PET scans, and we used it first in relapsed patients on a compassionate use basis. And this is a picture of somebody who's in the audience at relapse, and that's after 4 LuDo treatments. You can see that large mass in the pelvis responded very well. Sad it didn't go away completely, but it was a lot better. And we've published early data on the patients we treated before the trial opened. Now, many people think that once you've got an idea for a trial and funding for a trial, you can just do it. This is a timeline to show that it's in fact taken more than 3 years to get this trial going from the first idea. First of all, there was a number of approvals from scientific committees that was required. The Neuroblastoma NCRI subgroup, novel agents NCRI subgroup, the main NCRI's National Cancer Research Institute, Children's Cancer Leukemia Clinical Studies Group. It had to go for funding for the trial. The person working on it, Jenny Gaines, was funded through this charity, but the funding of the actual trial governance itself is funded through Cancer Research UK through its committee called CTAC. The trial then had to go and be approved by the MHRA, which is a quango called the Medicines and Healthcare Products Regulatory Agency. It had to go to an ethics committee where I had to go one evening and be asked silly questions. And finally it was approved. Then, having been through all that, it had to be approved in our own hospital, and that took forever. But last month we were able to administer the first dose to the first patient within the trial. We've experienced enormous delays. People are very unfamiliar with paediatric radiopharmaceutical trials. That slows things down. We're working within a very complex multidisciplinary team, so you've got to get all the bits to join together. We were hoping to open this at 2 sites at the Royal Marsden as well, but there are funding issues at the Royal Marsden which I understand are on the verge of being resolved, but not quite yet. The drug itself, there was a change in supplier when another pharmaceutical company bought out the rights from the first one, and then they decided, well, now we've bought this, we're going to put the price up. 5%, 10%? No, 300%. They trebled the price of the product. So that led to a big increase in costs that hadn't been budgeted for. The MHRA wants something, everybody likes these 3 and 4 lettered things. The MHRA wants something called an IMPD, and that is an investigational medicinal products dossier, which is an enormous big Bible of facts about the drug. We then discovered that we needed a new bit of kit, which again hadn't been budgeted for. We found the £15,000 from soft money. These aren't available off the shelf in John Lewis's. You have to order them specially. They take about 2 months to be built and delivered. And then if you're a private finance initiative, that wonderful concept of running hospitals, you then have to negotiate with the people who own the hospital, which isn't the hospital itself, about how much they're going to charge to put the thing in. And then there's a lot of health and safety issues, because there was an incident in America where the head fell off a gamma camera while the patient was on the table, and that was very bad news for that patient. But as a result, everybody has become much more risk aware, and these are enormously heavy because of the shielding fixed to the ceiling. There were a lot of bits of passing the buck as to whose responsibility it was to ensure that it was fixed safely, and that took weeks and weeks to resolve. So things don't go quickly. But anyway, that trial's up and running now and open. Just a brief word about MIBG, because it was a big word a few years ago. We still think it's important. We have a treatment schedule which we call MATIN, which is an abbreviation of MIBG and topotecan in neuroblastoma. It has a number of specific features, including drugs to make the MIBG work better. And we've treated a lot of patients with this schedule now, giving 2 doses of MIBG 2 weeks apart, together with topotecan. And we are now in discussion with our European partners trying to develop a new clinical trial called Veritas, which essentially would be a randomized study in poor responders, patients with high-risk neuroblastoma whose disease fails to respond well to initial chemotherapy. Quite a complicated study involving all the other treatments as well, like surgery and radiotherapy and immunotherapy, but to see whether MIBG is as good as or better than double high-dose chemotherapy, which is what some people in France think is a really good idea. This trial is taking every bit as long as the other trial that I discussed to make happen, but I hope that we can make it reality. So in summary, I've given you a rapid run through different sorts of radiotherapy. Radiotherapy is very useful, but it can be improved upon. and so we need to make it as good as we possibly can do. And there's a double approach for doing that through both physics and technology and also through biology. So thank you very much.